Welcome back to MLT 120. Today we're going to be learning about some different white blood cell inherited diseases, and these diseases are going to affect the morphology of those white blood cells that you're going to be seeing under the microscope. So the first anomaly that we're going to talk about is the Pelger-Hewitt anomaly. So this is a white blood cell inherited disease, and you can see some more images in your atlas on page 449 and 450. But this is an inherited anomaly that's autosomal dominant. So what does that mean? It means it's found on a non-sex chromosome. So you're not going to find the genetic information for this anomaly on the X or Y chromosome. You have decreased segmentation of your neutrophils. Usually you have your 2 to 5 segments in a normal neutrophil. So if it has decreased segmentation, you're going to have 2 or less segments. So it's hyposegmented. And you're going to have coarse clumping of your chromatin inside of your nucleus of the Pelger-Hewitt affected cells. And of course, the two neutrophils on this slide, the image, are both considered Pelger-Hewitt cells. These are hyposegmented neutrophils, meaning they've only going to have 2 segments and connected by a little filament. On the next slide, if you have a Pelger-Hewitt cell that has no segmentation, it's known to be homozygous, meaning the nucleus is round, and you can see that here in the image to the right hand side. This type of cell is also known as a Stadmeiser form of the Pelger-Hewitt anomaly, and you can see more images of this in your atlas on page 132 in figure 14.1c. If your Pelger-Hewitt anomaly cell has 2 segments, it's known as heterozygous. Sometimes you can also see bands in samples with Pelger-Hewitt samples. And also this form of Pelger-Hewitt is known as pince-nez, and that's French, meaning pinch nose. It can also look like a dumbbell, or said to look like a pair of glasses or a pair of spectacles. But take care not to confuse your Pelger-Hewitt cells with a shift to the left, which is where you're going to see increased bands or metamyelocytes. Remember, our metamyelocytes are immature form where our nucleus can look like the kidney bean. And also something to remember, this line right here, our neutrophils for our Pelger-Hewitt anomaly, they function normally. Okay, even though they're not right as far as their morphology, they still are able to function normally. Now we need to discuss something called a pseudo-Pelger-Hewitt anomaly. This is when you have hyposegmented cells within a smear, but they're not true Pelger-Hewitt cells. In order for it to be considered true Pelger-Hewitt anomaly in a patient, at least 50 to 80% of the total white blood cells or neutrophils seen have to be affected. If you just see 1 or 2 random hyposegmented cells, or cells that look like little glasses or dumbbells, that's not true Pelger-Hewitt. At least 50% or more cells have to be hyposegmented in order for it to be considered true Pelger-Hewitt anomaly. So if you just have a few random ones, it's not true. It's pseudo Pelger-Hewitt anomaly. The next anomaly that we're going to talk about that can affect our white blood cells is May-Hegland. The May-Hegland anomaly is also an inherited autosomal dominant disease. And again, autosomal meaning that it's not on a sex chromosome. So it's not on your X or Y chromosome. So they come with what we call an appearance of doughy or dull bodies. So you'll hear it said both ways. Some people say doli, some people say dull bodies in the neutrophil's cytoplasm. So what are these dull bodies? These are little bluish gray inclusions at the periphery of our neutrophils. So that's what these little red arrows are pointing to, are the dull bodies, or doli bodies, however you want to say it. These little blue looking inclusions. They are usually indicative of a rush to maturate or maturation due to the response of an infection. Okay, that's how we end up with those inclusions in our white blood cells. Also with Meheglin samples, a lot of times you'll end up with giant platelets or abnormal platelets. So normally our platelets are small little purple dots, so that's how they show up on a right stain. Here's a small platelet. But you can see this platelet is so large, or so giant, that it's almost the same size as this neutrophil. Here's a dull body right here in this example. But you have thrombocytopenia in these Meheglin patients as well, meaning they have a decreased platelet count. Okay, up next for our white blood cell inherited diseases, we have Chidiac-Higachi disease or anomaly. This one is rare and it's inherited, and it is also autosomal, but this one is recessive. Our two previous ones, Meheglin and Peger-Hewitt, were both dominant, but Chidiac-Higachi is recessive. Usually with Chidiac-Higachi, patients have recurrent bacterial infections, so they just keep having bacterial infections over and over and over again. Also, usually people with Chidiac-Higachi anomaly have varying degrees or extent of albinism. Usually they have lighter skin, hair, and eye color. Usually patients with Chidiac-Higachi die before the age of 10. It's usually a defect in the lysomes, and remember the lysomes from when we studied the cell, they play a role in the digestive system of the cell. They contain enzymes in order to help break down waste materials inside the cell. So because of the lysosomal defect, you end up with fused dysfunctional granules inside of your white blood cells. And hematologic findings include giant lysosomal granules in our granulocytes, our monocytes, and our lymphocytes. So this ends up causing ineffective and prolonged bacterial killing in our neutrophils, and it's just an overall dysfunction of these cells. So they're not able to properly do their job, because usually our neutrophils are able to kill off our bacteria, and they're not able to do their job when they have this Chidiac-Higachi anomaly, or affected by this anomaly. So let's actually look at the image of a neutrophil that's being affected by the Chidiac-Higachi anomaly. At first glance, you would think, oh, this is a hypersegmented neutrophil probably, but it's actually not hypersegmented. All these extra little purple splotches you see are not part of the nucleus. It's actually those fused dysfunctional granules that are being produced by the deficient lysosomes from the cell. Okay, it actually has a regular amount of, or a normal amount of segments to the nucleus, but all this extra stuff you're seeing, these extra little blobs, are those fused dysfunctional granules, and you can see a little bit better in this drawn image down here at the bottom. These granules actually look a whole lot bigger than they normally would because they're fused together. They almost look like a segment of the nucleus. The next inherited white blood cell disease that we need to talk about is the Alder-Riley anomaly. It is an inherited autosomal recessive disease. It is rare. It's dense clusters of dark staining granules in neutrophils. These are usually made up of mucopolysaccharide deposits. So what's a mucopolysaccharide? It's usually long chains of sugars, and a lot of times we find them in things like mucus or joint fluids. A lot of times these patients are deficient in their lysosomal enzymes needed to break down those mucopolysaccharides. So there's a couple of diseases that can end up with Alder-Riley anomaly cells. It occurs in Hurler's disease. It's a condition caused by a gene that children lack the enzyme to digest sugar. This was also known in the past as gargleism. And in this particular disease, patients usually have coarse facial features. They have enlarged heads, prominent facial bones, wide eye sockets, and flat nasal bridges. Also, in this anomaly can occur in Hunter's syndrome. It is a rare inherited, less severe disorder than Hurler's disease, but it's a disorder within the body where it doesn't break down sugar molecules properly. And occasionally you can find Alder-Riley anomaly in healthy individuals. With the Alder-Riley anomaly, you can see, or it can be seen in neutrophils, eosinophils, basophils, monocytes, and occasionally lymphocytes. But leukocytes' function is not affected in Alder-Riley. The problem is the heavy granulation with Alder-Riley patients can be confused with toxic granulation in neutrophils because they look very similar. Toxic granulation is a condition of neutrophils seen in response to a really bad infection, along with dull bodies and increased number of bands, metamyelocytes, and myelocytes. The last white blood cell inherited disease we need to discuss is chronic granulomatous disease, or CGD. It's inherited, it is rare, and this one is the one that is sex-linked, and it's recessive. This is caused by a defect in white blood cell function. It's a failure to activate the respiratory burst in neutrophils that kill ingested bacteria. So what's the respiratory burst? It's a rapid release of O2 that helps kill pathogens. It's fatal. This particular disease is fatal in childhood due to infections. It's life-threatening, catalase positive, bacterial, and fungal infections. So infections are allowed to take over the body because the white blood cells cannot do their job. We use the NBT test, or the nitrosolium blue test, to diagnose. This helps measure the respiratory burst using flow cytometry. And again, we use it to help diagnose for CGD. Some symptoms for the chronic granulomatous disease include swollen lymph nodes, chest pain, fever, runny nose, swelling, and redness in the mouth. Again, you have frequent bacterial, fungal infections. Also, abscesses are something that happens with this disease quite often. And if you'll look at the diagram, you have your neutrophils, and they usually are able to phagocytize foreign microbes. So that's what it's doing here, is phagocytizing or eating the foreign microbe. And normally it would ingest or kill off the microbe, but in this disease they're not able to kill off, and the microbe will survive and eventually the infection is able to take over the patient's body. That concludes this lecture on inherited white blood cell diseases. I hope you learned a lot about these 4 diseases we covered today, and I will see you over in the next lecture.